Hello and welcome. I'm Dr. Adam Dorsay, a psychologist in Silicon Valley and the host of SuperPsyched, a podcast dedicated to supercharging your life. Each episode contains fun, high-quality interviews with experts looking at psychology from all angles. SuperPsyched is your tool to get more of what you want in your life and less of what you don't. I'm going to say something that sounds so obvious, you'd imagine it's research that came from the University of Duh. Here's the statement. Women have ADHD. Sounds obvious, I know, but here's another fact. Up to 75% of those women have gone undiagnosed. This is a big deal. Many lives of women have involved unnecessary suffering without the diagnosis. As mentioned in my episode with Dr. Ari Tuckman, the quality and even quantity of people's lives can be at stake when there is no diagnosis rendered. But fear not, help is here. Dr. Michelle Frank is a psychologist and the co-author of A Radical Guide for Women with ADHD. This excellent book, which she co-wrote with Sari Golden, is required reading and has been praised by one of the pioneers of ADHD information, world-renowned psychiatrist Dr. Edward Hallowell. Dr. Hallowell has also said, whenever you get someone with ADHD diagnosed, treated successfully, everyone wins. So if you are or know a woman with ADHD, listen, as Michelle shares crucial information about women and ADHD. Dr. Michelle Frank, who's asked me to call her Michelle, welcome to SuperPsyched.
Thank you. I'm so happy to be here.
Oh my gosh, Michelle, this is so much fun. In fact, I would even say it's kind of a dream come true, and here's why.
Okay.
I went to the Psychotherapy Networker Conference in Anaheim. God knows how many people were there. All of these therapists from all over the world. Alanis Morissette was there, and she destroyed. And the first session I attend is yours about adult ADHD and trauma. And I took front row center and just basically geeked out, looked at you, took copious notes. And I felt like, oh, thank God, somebody's actually describing not kind of my experience, but exactly my experience. Yeah. And so I'm so happy that we're going to be talking about ADHD in women today, because I remember learning about ADHD and gender. And at the time, the stats seemed to express that, yes, women experienced ADHD. They were rightfully diagnosed with it, but at far smaller numbers. And now we are seeing, wait, hang on, the differential is hardly there, and that women are being overlooked. We call it diagnostic overshadowing in the biz. And I wanted to just kind of talk about, like, why is it that so many women go through life without even realizing they have ADHD?
Yeah. There are so many reasons for that. What we do know is that actually adult women are really leading the way in terms of seeking out diagnosis, seeking out therapy, and having prescriptions filled for ADHD meds. So women are very quickly catching up. It's almost like women see a problem and they get in there to do something about it. It's a cool thing. It's a great thing, right? Women are just a little more likely to go to therapy and kind of seek out some of these diagnoses at this point in time. And that's a really wonderful thing. And I would say it's still lagging for younger girls. And we're still seeing this pattern of later in life diagnosis as well.
I hear about this all the time, by the way.
Yeah.
You know, I'm 53 years old. She'll say to me, and finally, I was diagnosed. And all of this time, there's the relief in the diagnosis and the sadness about the time that could have been better if only the recognition and the treatment was there. So let's talk about that. Let's say somebody does get diagnosed a bit later in life. Let's talk about the relief, perhaps the grief, and maybe some of the trauma in the rearview mirror that may all be there.
Yeah. The beautiful thing about getting a diagnosis at any point, especially though I think when you're an adult, is that it comes with a great feeling of agency. It really rewrites the narrative, looking back in the past and then looking at yourself now and then looking into the future. And so diagnosis is important in that way, that it gives people a name, it gives people an understanding, gives people access to treatment and community. But even deeper than that, it gives them access to a sense of agency within themselves that really tends to rewrite the whole story. And like you said, there's a lot of layers to this when women come in and get diagnosed later in life. On the one hand, there's, like you said, great relief. There's like, all right, well, now we're off to the races. Now we can do something about this. And many, not all, but many have some grief looking back, saying, gosh, would I have made the same choices in my life had I known? What could have been different for me had I had the right supports earlier on? Why didn't the adults help me more? And so you're really left with these really deep questions that really like center around some relational wounds about like, how did the people and systems and structures in my life show up for me or not? There's can be great gratitude, like, wow, I really learned how to make my way. I came up with some great skills. I compensated really well. I'm proud of myself. Look at all I've done. And yet, what would have been different if I had known? So it's a mixed bag.
I hear about that one all the time, and it really resonates with my own experience. I was diagnosed at 27. Yeah. I remember very well, and listeners who've heard me talk about this on this podcast, my apologies, but for those, there are many who haven't. I remember being finally and correctly diagnosed by Dr. Hugh Reidelhuber, who, to whom I owe a tremendous debt. He really gave me a battery, and he said, absolutely, unequivocally,
you needed a battery, Adam? I mean, come on.
He was thorough. He was
thorough, just in case.
He was thorough and responsible, let's just say.
Yeah.
But for sure, no, I got the joke. Looking back, it seems like the biggest duh. But he prescribes me short-acting Ritalin at 10 milligrams initially. And of course, listeners, this is not medical advice for any of you. This is just my experience. And I take it and I don't drive. I sit in my car and wait. And I remember within about 30 minutes, the sensation was this. Oh my God, this is what a normal brain feels like.
There I am.
It's not like it suddenly alone took me to the land of Oz, but it gave me the kind of scaffolding I needed to create what I needed to create. And I'm so grateful.
Just a quick note on meds. That's what medication should feel like. It should not make you feel numbed or like a zombie. It should not make you feel euphoric or high or like you can't break away. Like what it should feel like is you put on your glasses and you're like, oh, it's like, there I am. Oh, there's my brain. Or to someone who maybe doesn't wear glasses, like just imagine you're hiking in the mountains on a really sunny day and you pull your sunglasses out and you put them on. You're like, oh, right.
I see so much better now. My eyes feel cooler.
Yeah. But only your brain. Mm-hmm.
I love that you're using a prosthesis like this to describe an exogenous chemical like Ritalin, because there's so many stigmas against it. And yet no one would think twice about, I don't think, about putting on sunglasses and how awesome they feel. Right. Let's talk about the stigma, because one of the things that I'm sure that you see people wrestle with is, okay, now I've got the diagnosis, but I've been told that the medication is bad or it's meth or blah, blah, blah. Let's talk about that.
It's certainly centers around medication. You know, a lot of the people I see in my therapy practice have so much shame around the meds that I need to remind them it's okay to take them as prescribed. Mm-hmm. But the narrative out there is that people who use stimulants are substance abusers, which isn't true. It's just such a complex array of problems in that argument in the first place. But even aside from the medication, I mean, I have people come into my office who have been thoroughly diagnosed, and then they're coming to see me and I'm like, yep, that tracks. And they're still like, yeah, but what if it's just me? I just don't have it together enough, right? I don't think I have ADHD. Like, I respect that other people have it. I think I'm just kind of a mess of a person. And so it really fuses with character and identity. I think that is a product of not having a construct to wrap your mind around earlier in life around your neurodivergence, right? To be able to say all brains are different, and here's how we support that in our family, and here's how we work with that at school or whatever, soccer practice, here's what we do. If you don't have that construct, you are really left with the sense of I am different, difference is bad, I'm a problem, I'm broken. And it takes a really long time to unweave that web.
So many voices, so many authoritative adult voices come into our lives saying it's a question of character. It's just if you would get it together and just have more elbow grease, you'll be fine. And so, of course, we come to this conclusion, well, it's just me.
Yeah.
And we fight that because on some level, we have heard that so many times that we want them to be right. I'm not suggesting that this is absolute for everybody hearing that message, but probably a theme or variation has shown up where we misattribute our neuro differences to a characterological thing. And it's not characterological, it's neural. In as much as I'm presently finally acquiescing to the fact that I do need to wear glasses, which has taken me a long time to actually accept, a lot longer than it took for me to accept that I would need medication for my ADHD. It became kind of a joke between me and my wife. I'd be like, I can't read this damn menu. And she's like, would you wear your glasses, please? But we all struggle to come to terms with these changes of self. And I love that you said that. I've seen that in my office too. It's just me rather than, What are some differential diagnoses that should be ruled out, by the way? Because it's not always ADHD that is attributable to these problems. What would somebody be wise to just check to make sure it's not X, Y, or Z, because we don't want to address the wrong thing with the wrong protocol?
Yeah. A lot of things can look like ADHD, and ADHD can look like a lot of things. It is complex, and I'll say ADHD also rarely travels alone, which makes it even more complicated. But
it's a very social situation.
So we're looking at things like mood disorders, depression and anxiety, certainly like severe trauma experiences that have led to like trauma response, complex PTSD or PTSD can go with ADHD and mimic ADHD. And then I think you're also looking at sleep disorders, having those ruled out. Anytime someone comes in and they've had a history of head injuries, then we're talking maybe we need a full neuropsych to make sure that there isn't some organic damage going on. So you're essentially ruling out the DSM to rule it in.
Exactly. So very often ADHD, as I described it, it's social, it's friendly, it's got coexisting issues, anxiety, oftentimes mood disorders. So we would want to rule them out, and yet also recognize that we can rule them in as well as coexisting.
But I do want to say for women that those coexisting anxiety disorders go way up, and depression as well. They happen for men too with ADHD as co-occurring conditions, but women tend to have higher rates of co-occurring depression and anxiety. And a lot of times women are put off for years saying it's just depression or it's just anxiety, as if those things aren't really difficult on their own. But then they treat the depression and anxiety, and then they're still left with ADHD at the end of the day. And similarly for women, one thing we really need to be looking at is PMDD. And we really need to be monitoring them closely postpartum as well, because there's higher rates of postpartum depression and anxiety for women with ADHD.
And PMDD is?
And PMDD, premenstrual dysphoric disorder.
Which is a thing. And I remember some people kind of rolling their eyes when this diagnosis even hit. And every woman I knew was like, what are you talking about? Yes, this is real. Can you talk just a little bit about what that can look like, that premenstrual dysphoric disorder?
PMDD for folks, it's much more distressing and impairing than a typical like premenstrual experience. So people with PMDD have crushing feelings of depression or panic leading up to their period. They tend to really, really struggle in that second phase of the menstrual cycle from ovulation on, and then they'll start feeling back to normal, sometimes the day they get their period, or certainly within a few days. And then they'll feel back to being kind of regulated and responding in emotionally appropriate ways to things happening in my life and making good decisions. And then bam, you hit, week 2, and they're just like in a really deep hole, just tearfulness, tons of anxiety, tons of low mood, tons of negative thoughts, rumination, and it really feels terrible for them. And so it's really important when that's happening to begin to recognize what the pattern is, and then make sure we're talking with both a prescriber and a gynecologist to see, Is there anything that needs to happen hormonally as well as psychologically or psychopharmacologically? Because it could just really be crushing. And we know that women with ADHD are more likely to experience PMDD. Even with ADHD who don't meet criteria for PMDD, I'll say they often feel their ADHD gets worse premenstrually because estrogen upregulates dopamine. And so when your estrogen is low, if you're already low on dopamine, then you're really at the bottom of the barrel there, and your brain feels that way. Same thing can happen in perimenopause. We have some research coming out saying women with ADHD have perimenopause with greater intensity, possibly even earlier. And certainly then when full menopause comes and your estrogen is really depleted, all women are going to experience some cognitive changes, some executive functioning challenges. But if you've lived your whole life, again, already in a bit of a deficit there, you're really going to feel it. And so a lot of times women need to adjust how they work with their ADHD, how they understand what's happening, how they support themselves, not just different times of the month, but throughout the lifespan.
So crucial, and how these don't exist in a vacuum, that these really impact each other. And by the way, just an asterisk, when I said every woman I've spoken to, I meant every woman I've spoken to with PMDD has told me, yeah, this is definitely real. And the good news about many of these conditions is we've become so surgical in terms of figuring out which medication will work best for each condition for each person. For one person, they might find that Adderall is really the way to go. And for another person, it could be old school short-acting Ritalin. For somebody with PMDD, it might be an SSRI, it might be something else. But we've become very good, and it's really important to communicate well with your physician as you go through these. I'm wondering if you could share with the listener, if you're comfortable doing so, your own story with ADHD and how you got into this.
Well, so I was the girl with ADHD who no one would call it ADHD. It was just, we lived across the street from my school, and I made really good friends with the janitorial staff because I was always forgetting all of my stuff, and I'd run back and I'd knock on the door, right? They always knew, like, it was always me forgetting my stuff again. Family joke, right? Lost a brand new camera I'd gotten as a Christmas present, on a family vacation, just crush. And it was just sort of like, yep, of course, or the clumsiness, or I was in AP English and I was particularly struggling with activation and not feeling motivated to write a paper. And he had us do blind grading. And I think the name I put was something ridiculously adolescent and angsty, stupid, like no motivation, right? And he circled it and said, I can tell, and gave me a C. And I thought that was more than fair. Yeah, actually, I thought it was more than fair.
It was fair, but it was
it was soul crushing, but also more than fair. I was like, yeah, that's true. So there were signs. There were some signs. And I think I was sort of seen through the lens of someone who struggled with some of these things, but also was a good student, had a good head on my shoulders, and struggled a bit with self-esteem and anxiety. And so it was not fully missed, but we didn't really have a category for it in the 90s for women. And then I kind of go on about my life, and it keeps popping up here and there, right? Like at different doctor's appointments, but nobody really does anything about it. And then I think college, I finally had a psychiatrist call it out. We did not do medication straight away, though, which was interesting, but we did talk about it. And then in graduate school, it was such a mixed bag. On the one hand, I was soaring, and on the other hand, I was drowning. It was like I was never one, clearly, to care much about getting straight A's. I'd always been able to kind of do well enough, and that was good enough for me. When I got to grad school, I was so fascinated in everything that the grades came really easily because I finally found my special interest, and my brain was just lighting up constantly. But the amount of reading and writing you have to do, and the time management that goes into that when you're in a doctoral program is crushing for a neurotypical. And I felt like I was just treading water all the time. And so here I was and like, oh my gosh, I actually feel like I'm smart and interested in things. And like, this is great. I had some great friends. I was living in downtown Chicago. This is great. And yet secretly, kind of behind the scenes, I just felt like I was falling apart. And so I really started doing a lot of my own work at that time. And then I tried really hard to be a play therapist and just work with kids with trauma. And I really loved that. But there's just some issues systemically there that were really challenging in working with managed care and these sorts of things. And over time, I kept seeing more kids and then teens and young adults with ADHD. And I was doing some assessments at the time. And I said, okay, I think I'm actually like ready to maybe take this on in a way that I just simply didn't have the confidence to earlier on. To work with something that you experience yourself actually is not the easiest thing to do because it's so close to home. And so I felt like I really had to be ready. So I did a lot of my own work around that time in my early career. And I started going to all these conferences because, in grad school, I learned like the DSM criteria for ADHD, which is still mostly based on white hyperactive school age boys. And my mom had been a college counselor and she had gone to some of these ADHD conferences back in the day because she's the frontal lobe of our family. And she said, well, you've got to go see Sari Solden speak and you've got to go to this conference. And Ada and Chad, at the time they did separate conferences, you've got to go to these. And so I did. And I just very impulsively walked up to Sari at one of the conferences and was like, how can I be you? How can I do this thing that you're doing? You're a woman with ADHD. You're out about that. You're also writing and teaching and you're working with women with ADHD. And how do you do that? And so she really kind of took me under her wing. And then I just absolutely fell in love with it from there on. It was just a delight.
There's so many things that you're saying that are bullets that I want to attend to, but I'm just going to say this. First off, a white male model for ADHD with hyperactivity does not allow for the other expressions of it. So when they see somebody like you, or even me, because I have the inattentive type, I'm ostensibly a white male. And I say ostensibly because I have other ethnic features, but that's not for this podcast. And I was staring out the window, harmless. So the teachers really didn't give a crap all that much because it was kind of annoying when they'd call on me and I didn't have the answer because I was spaced. Yeah. But in your case, it seemed like the idea, the urgency to include medication in the mix was partially because you didn't meet that mold, let alone get that diagnosis. Yeah. And to see Sari and say to yourself, wait, she could do it. I might be able to as well. And then fast forward, I see you at a podium commanding an audience of licensed professionals who know a lot but need to know more because you're that good at this. And I hear about you from thought leader colleagues and how highly they regard you. And yet I want to talk about your imposterism because I know that you must have it because everybody does. And one of the things I want to let the listener know is just because you have imposter syndrome doesn't mean you're not ready for the job. It might mean that you know a ton about the things and you're aware, unlike some people with Dunning-Kruger who think they know everything. Dunning-Kruger, by the way, is like what I call the Homer Simpson syndrome, when you overestimate your abilities versus what they actually are. But let's talk about imposter syndrome and how that may have shown up for you and how it may be true for many women with ADHD.
Yeah. I think for a lot of women with ADHD, it's like we learn to mask very early and we learn to perform very early. And so we're great internalizers, right? Boys and men tend to be externalizers, not always, but more so. And girls and women tend to internal. Things go inside, and then we're really good at trying to keep the show together, keep people connected, try and stay in relationship and caretake, all these things. And there's a lot of sociology involved in that. But I think we learn to mask so early on that it feels sort of like I have the mess is behind the scenes. And I remember just feeling so afraid at first for people to see that and know that. And in fact, one of my early clinical placements, I remember they commented on the mess. It was just kind of crushing. For years, I didn't want to have people over to my house, my good friends over to my house, right? Because then they'll see the mess. And it was just such a metaphor. I mean, come on, right? Such a metaphor of that vulnerability of being seen. And if they really knew that I have these struggles, will they think less of me? And the answer I found, continue to find time and again, is no. is that people really connect with vulnerability and honesty and authenticity. And I've been able, I think at this point, to turn around the imposter syndrome and say, how about we focus on vulnerability? How about we focus on modeling that discomfort? And how about we focus on cultural and intellectual humility? That's different than imposter syndrome, but right, it kind of owns that we don't know everything and we don't need to, and maybe we shouldn't. And so I've just done a lot of work on it over the years. And the cool thing is that I get really excited talking about this stuff. And so my excitement, my curiosity leads, but that doesn't mean that the imposter or the anxiety around it isn't there, because sometimes it still is.
I'm so grateful to Brené Brown for defining a host of things in our lexicon, including that vulnerability is a precursor, a necessary criterion for courage.
Yes.
And I'm so grateful to my father for asking me shortly after I was licensed, what's something that you really want to do within the next 5 years that scares you?
Ooh, I love that.
And I love that question because, as Oprah Winfrey reminds us, everything we want is on the other side of fear. And every time we knock down one of these clowns, I call them knocking down clowns, because they particularly creepy clowns, like they're in our way. Let's knock them down and move forward. Because on the other side of that fear is actually everything we want. Yeah. Don't let the clowns get in your way. And mastery. One of the things I would have my kids repeat on the way to school most days of the week, there were certain things I have them repeat almost. Okay. One of them was, repetition is the mother of mastery. And for us with ADHD, I think it's all the more salient that we have to repeat the good stuff, not the bad stuff, because unfortunately we might master the bad stuff in terms of our own self-talk. So
literally our ADHD brains are more likely to pay attention to negative stimuli or negative context, and then we hold on to it longer. And we also have greater valence. We call it emotional valence when it comes to experiencing things in a negative way, meaning like it's literally like on our skin and it feels heavier. And so we do process some of these things differently, and we are more likely to be scanning for that rejection or judgment, that threat. And so, we've got to throw it into manual override, right? And not just let the default setting, that automatic default take over.
That rejection sensitivity and the fact that you knew the janitorial staff. I also kind of knew the janitorial staff too, because I mean, the number of times I needed assistance from these adults who kind of roll their eyes and be like, okay, that's Adam again as a kid. Boy, the negativity bias is on spectacular overdrive for us with ADHD because we've been criticized probably more than the average bear. Can you actually quantify it? Let's go with women. How much more criticism do they receive relative to their non-ADHD peers?
I couldn't quantify women specifically, but what some of the researchers say is that children with ADHD receive 20,000 more negative comments by the age of 10 than neurotypical children. If you think about it, it makes perfect sense. Stop that. Sit down. Come here. You're not listening. Your head is in the clouds. Why'd you forget that? You just need to focus harder. You can play your video game, but you can't write. And so it goes on and on and on. And it's sort of like everything is a, why can't you just? And the biggest problem with that is that's exactly what the person themselves is asking themselves. Why can't I just? And then it becomes a shame thing. And look, I think there's absolutely a need for working on developing strategies to support executive functioning and ADHD symptoms. But frankly, like, you can have the best time management and the best organization system in the world. And if at the end of the day, you're still struggling with this thought, I am not worthy, I'm not good enough, I am broken, then to me as a therapist, that's a much bigger problem.
So let's go through a virtual sequence of a female being diagnosed and implementing the various treatments and the possible outcomes. Just kind of like, let's say Susie is a 17-year-old who has not been perhaps performing at her expected level, given her other testing seems to indicate that she'd be doing better than she actually is. What are the things that Susie might experience as she's being diagnosed and treated and beginning to kick some major ass in her life?
Like, what would we expect to see as things change?
Like what were some of the things that need to happen for Susie to really be off to the races?
First, I think the adults around Susie need to start looking at factors other than academic performance. They need to be looking at things other than output and say, how are you feeling about yourself? What is it like to live in your brain every day? What do you experience as you go through the day? If I were in your pocket or on your shoulder, what would that be like? And having some adults come into her world with curiosity would be a game changer. And then for her to be able to reflect on that instead of just focusing on grades or how many times she's late to school or practice, but like those are indicators, but they're not the whole picture. And I think a big reason we miss the boat on a lot of adults who weren't diagnosed in children is because we're only looking at grades specifically. Or are they a pain in the butt to the teacher? Are they a big enough behavioral problem? And so we need to be kind of asking different questions in our diagnostic process. A lot of the questions we ask, a lot of the questions on rating scales, again, still rooted in a male experience, white male experience. So she'd be asked different questions, right? But then, so depending, she may go through full neuropsych or psychoeducational testing if she does need accommodations. Let's say she does struggle, for instance, with test taking or something like this, or she does want some accommodations at college. She might go through full testing, maybe, maybe not. Unfortunately, sometimes the accommodations for ADHD fall short because like I don't really need extended time. I test too quickly. I need to learn to slow down. And that's something I might need therapy or coaching for to figure out behaviorally how to change. Or the problem isn't in the classroom, it's actually when I get to the dorm. So she'd probably begin to look at what supports are available to her. Some lifestyle changes might be. We'd be looking at getting her some support academically, but also just in terms of daily functioning. Some people choose to do ADHD coaching. And there are coaches they're not just life coaches, they're actually go through ADHD specific training through the ACO. And that's very important. I bring that up. It's very important that if you do seek out an ADHD coach, that they are associated with the ACO because they have some certification and they're actually supervised in that training. So maybe Susie would learn some like just really great basic lifestyle accommodations and supportive strategies. Maybe she'd enter into therapy and begin exploring what this means for her. And does she feel different with other people, with her friends? Does this impact how she talks to herself? Does she motivate with an inner critic like many of us do? How might we talk to ourselves differently? How can we embrace difference? Have we internalized any ableism over the years? Very likely, right? So that's what some therapy might look at. Ideally, her family would be saying, hey, this is great. All brains are different. How can we support you? I'm sorry for the hard parts of this. I see that parts of this are, in fact, really hard. And I validate that. And I'm so sorry for that struggle. And I'm here for you in it. And you're not broken. We love you. And you're going to rock it. Let's figure that out together. So I think ideally we'd see some connection. And with all of those things in place, I would guess to say Susie would do pretty darn well figuring it out. And she would also surely continue to have ADHD and not just have it, but actually have it happen, Adam. This is a huge thing. People with ADHD can get very comfortable these days saying, I have ADHD. But then to have ADHD happen, to forget something really important, to let down your partner, to show up late to something that you absolutely don't want to show up late to, these things are going to happen. And that's when we really want to stay out of that shame spiral and say like, yep, there it is again. How do we just course correct and get back on the horse? Instead of saying that treatment looks like ADHD never happens again.
Absolutely. I love that. It's not like, okay, problem solved. We've conquered the beast. No, it's an ongoing relationship, as you say in your book, until the day we die. And the premise of the question, why can't I just? I've often said that the quality of, I learned this from somebody else, but the quality of our questions determines the quality of our lives. And if we ask crap questions, we're going to get crap answers. That is for sure. So the why can't I just is immediately destroyed by the fact that you just shared with me, as it relates to this imaginary individual, Susie, a multimodal approach. Many different things have to happen in order for this to work. Before I get to my final question, what are some just of your basic tips for women who have ADHD? Just some things they can do or say to themselves or to others.
There are a few absolutely essential things that you need to do as a woman with ADHD. One is to learn about it, and the other is to connect with other people who have it. Because having ADHD in a silo is a recipe for shame and isolation, right? And just feeling like you're the outsider. And there's nothing quite as healing as being in connection with other people who are neurodivergent. And you can find those groups online. You can find them with groups like ADA and CHAD at the conferences every year, things like that. So that's absolutely pivotal. But aside from that, I think it's really developing a relationship with yourself and with your unique neurotype and brain profile, and being able to talk to yourself kindly, really practicing self-compassion, which is actually a lot easier said than done. Like, to actually make time to practice that every day, it can be tricky, but it's a really important part of trying to get to a place of motivating yourself from a place of affirmation and being value aligned, as opposed to motivating from an inner critic who's only going to take you down.
I love that. And self-compassion is something I've been working on. I've had Chris Germer, who is one of the key researchers in how to actually apply the technology of self-compassion to our lives. He's even stated that the Navy SEALs use self-compassion techniques to have better and faster results. It works. If the Navy SEALs are using it, we know it works. And one of the roots is speaking to ourselves as we'd speak to a friend. But if you're interested in that episode, check it out. What you're describing right now, Michelle, is just, it cannot be overstated. It's something that will work a lifetime to get better at doing, but it's a huge return on the investment of energy. I got to ask my final question due to time constraints. I could talk with you all day, but here it goes. Michelle, if you had the power to confer upon all humanity one insight or skill that would dramatically improve the lives of the individuals, and since we're all connected, perhaps the people around that individual, what would that skill or insight be? And how do you imagine the lives of the individuals, as well as perhaps society at large, might benefit?
Given our talk today, I think I'm going to go with taking small risks to lean into vulnerability. I think that's got to be it. Because that's where you grow and that's where you connect. And when you're growing and you're connecting, you're healing.
Fantastic. I love that answer so much. It's not like I'm rating answers, because I love all the answers I've received. But given what we've talked about today, that resonates just so deeply, even in my life as a male with ADHD and who's struggled. This is outstanding. And I hope you write that prescription to many, because I think that the benefits could be huge. We all need to show up with our strengths and our light. ADHD does not have to be a curse. It can be a blessing. And we didn't really get into that, but let's just say the upside to ADHD is also there for another conversation that I hope to have with you at some point, Michelle.
Would love it.
So much fun to talk to.
Thank you, Adam.
This is Dr. Adam Dorsay thanking you for listening to SuperPsyched. If you know anyone who might like it or who might benefit from listening, share it. And if you like the episode, please hit subscribe.